turn things over to the team to kick things off. And Syed, are you starting things off?
Yes. Good afternoon. This is Syed Ahmed. Hope you can hear me well. I don't know if you can see me well or not. If not, I will continue talking though. Again, good afternoon. Thanks to Rachel, thanks to RWJ, and thanks to all the people who are on the phone and webinar today. So we are going to talk about Milwaukee Prompt, Prevention of Opioid Misuse through Peer Training Program we have for last so many years. Before I go further, I will talk about the agenda. I like each of my friends and the clinical scholar peer partners to introduce themselves just like a 30-second. And first, Kevin.
Hi, Kevin Hamburger. I'm a psychologist at the Medical College of Wisconsin and one of the clinical scholars on this project.
Kajua.
Hi, I'm Kajua Lore. I'm a clinical pharmacy specialist and I'm chair and associate professor with the Medical College of Wisconsin School of Pharmacy.
Rob.
Hi, I'm Rob Hurley. I'm a pain physician and a professor at Wake Forest University.
Wonderful. So our agenda is in front of you. I'm going to give you some background of our program, background of MCW, because that is what it is, the context is for our program. We'll talk some about our project planning, design, its work, evaluation, and of course, next step. We'll also talk briefly about the lessons we have learned so far from each of us. So at the very end of the talk, I'll come back again and each of us will talk briefly about the lessons we have learned. So I like to move to the next slide. So if you look at the pictures in front of you or the slide, you see many partners. Other than Medical College, we have Dry Hooch of Wisconsin, and it is located in Milwaukee. It started about 10 plus years ago by Bob Curry, a veteran, and it is to help the veterans coming from different wars with the social and other suffering they're facing, how to really take care of many of the issues they face, which is not always easily taken care of. We have also partnership with Mental Health America Wisconsin. They help doing the peer training with many folks, and they also provide psychological and other support for the veterans. They have other programs also. You see also in the list, other than MCW, we have Wake Forest Baptist Medical Center, and that is mainly because Rob decided to leave warm Wisconsin to cold Carolina a few years ago, and glad that he has still stayed with us. We're delighted to have him as our good friend and colleague. And of course, RWJ Clinical Scholars, we take them as our major partner in this major venture. So these are the major partners, but we have other partners we may briefly mention as we go along with the whole discussion today. Before we go to our prompt program, I thought it would be important that I talk briefly at least about the MCW and show what community engagement means to us at the medical college. It is a private medical school, about 125 years old. It had many different names. The last name was Market Medical School, and around 50 some years ago, the name changed. We have 4 missions, full missions: community engagement, education, research, and clinical care. That is actually uncommon. Most of the medical school has 3 missions: education, research, and clinical care. We are one of the less than 10% of the medical school has full mission of community engagement, which is, as I said, more exception than the rule. But if you saw some research 15, 20 years ago, there was less than 1% of medical school had anything to do with community engagement. So there is a significant progress, and we are part of it. MCW identified community engagement as a full mission in 2008. And since then, or even a few years before that, we have been developing many different programs. We established the Office of Senior Associate Dean for Community Engagement and became the inaugural Senior Associate Dean in 2012. And there are many other milestones worth briefly mentioning. One is Carnegie Classification for Community Engagement. So we have made significant progress in community engagement to the tune of more than 300 initiatives in 2018. And you can see some of the numbers of partners and the faculty activities. We also have data on faculty, each faculty doing community engagement, each staff. So we have about 350 plus faculty and 320 plus staff has done some community engagement in 2018. So it's a huge number. If you think about 15 some years ago, we barely had 2 or 3 faculty was involved in community engagement. So I would say a significant stride. And that led us to even getting a national recognition like chronic classification for community engagement in 2015, being only one of the 4 medical schools to ever receive that designation. We also received 2017 the AAMC Community Engagement Award called Spencer Foreman Award as a finalist, but about 5 years prior to that, we did get the full award. So this is very brief background. So I'd like you to take another couple of minutes to look at a video just to have a glimpse of community engagement at MCW. Community engagement is a concept that the academic institution like medical colleges have to engage with the community to get their communities involved in their own health and healthcare outcome.
Community engagement to me is another term for almost like a marriage, a partnership.
It doesn't involve coming to do things to the community. It's doing with the community and for the community.
Community engagement is one of the approaches that I would say that brings research to the real world, makes it very applied.
It really values the community voice.
It builds a trust. It's an opportunity for the community to see that things have changed, that institutions are sincere.
And that actually improves the validity and reliability of our results, makes them more applicable in other populations when we try to figure out is this generalizable. So there's a lot of scientific reasons to engage in community engagement.
Some of the key skills I think that are important for academic researchers is be able to engage.
It's an opportunity for the academics to actually get to know people in those areas, get to know institutions and organizations, and get to understand their issues and see things from their perspective.
So this is just a glimpse of MCW community engagement. So if you look at the next picture, there are a few folks in there, and I don't have, I think, time to go through each person, but our community engagement, the prompt program, is far larger. Many peers, veterans involved, the dry hooch folks involved, VA hospital involved, practicing physician, family physician, PhD researcher, and of course the peers. So this is a program built on our existing relationship, but taking to the next level. And always in the community engagement, taking to the next level means a huge amount of work and addressing something in particular. So why did we choose, next slide, why did we choose this particular issue? I don't think at this moment there are not too many folks who doesn't know that we are having epidemic of opioid misuse and crisis and death and suicide, what do you call drug-related deaths, all over the country. This is actually an epidemic that was brewing for years, and some of us has been actually involved in discussing this challenge coming in the past. But anyway, last so many years, it became more real that people understood it is an epidemic. This has to be really addressed. So this is a challenge for general mass. For veterans, however, it is even bigger problem with all multiple factors that affect their health and healthcare access. So they have trauma that is understandable, that connects to the pain prescription, chronic pain, and then social isolation. This is a big part to remember. Social determinants of health we talk about nowadays quite often. Veterans do see basically all 30 social determinants of health and their impact on their health. This is very real for them. So it is a very complicated problem to reach. So we chose the problem which is really complicated, really wicked. And why did we choose them? We chose it because of many factors. Number one, we had the existing relationship. We had the existing relationship which helped us to continue to work together, and we had the trust relationship. Community engagement is built on trust. We had 10 years relationship with them. So we wanted to address all the multitude of issues they face, not only for the opioid, opioid-connected depression, anxiety, PTSD, you ask for it, people go suffer through this. But one thing you have to remember that this is just a glimpse of what people go through as the opioid crisis goes through, but especially for vet, these are real, I think real, and that's the thing we are trying to address. Next slide. Well, one other slide just to show you that there are a huge number of deaths. I think map is in front of you, so I don't want to go through each number, but few numbers to remember. The 2017, there were about 70,000 drug-related deaths. There's about $80 billion economic burden in 2017. And by next 10 years, more than 650,000 will be drug-related deaths. So these are all very much tremendously impacting our health and healthcare. Next slide. So what did we do for our program? What we are talking about? We are talking about coming up with a work, knowing that it will be difficult, coming up using all our experience and collective expertise. And as we all know that it is not an easy one. So we decided that we'll address it, not just having the peer and vets as the target population, though that is the target for our program. They are partnered at every level, from the inception of this program all the way to development of the modules and now implementing. The peer mentor also helped even creating the modules, but also among the clinical scholars with the background in family medicine, psychology, anesthesia, pharmacy. We have other expertise along with people who are part of the advisory board with lived experience. All of those collectively decided, came up with this idea. So we have this partnership at multiple levels, which is moving forward with the idea that we can address it, but we have to address it in the very ground level in a very real way. That's what we are at. Next slide. So we have history of developing peer program in many other settings, also Dry, which has history. Few things about Dry, which I think it's a good time to let you know. It is a 501c3 nonprofit veteran organization developed by a gentleman, Bob Curry, a vet himself, a wonderful person with many other folks. They provide peer-to-peer program for PTSD and alcohol and other program, family group sessions, legal support, then employment, placement, and some other social help. So this is an organization that has been doing it. And because they are like friend to the other vets going through the process, it made a lot of sense creating a peer-to-peer mentor program. They're like friends more than anything else. They have similar lived experience. So it creates a different environment of addressing an issue which is more accessible to them. So that's the reason we decided we want to create the peer mentor model. And this is the one I think we can sustain it because of the relationship we have built, and we have other programs which has been going for a long period of time. So what I like to do is, this is a very brief overview from my side. After this, all of the other presenters will come. First, Rob will talk about the next part of the discussion, and then successively Kajua and Kevin. So I'm going to turn it over to Rob now.
Excellent. Thank you very much. So what you're looking at right now, just a quick slide to orient people. The gentleman on the far right is Otis. He's our lead peer mentor. And then the gentleman to the far left is Bob Curry. Now, what they're doing is they're working with the young gentleman in the middle, who is a student from Marquette University, and they are working on the iPad and Android app, the iPeer app that is part of the program. If you could change to the next slide, please. All right, so the overall goals of this project, we are trying to prevent opioid use disorder, or really opioid use disorder related deaths among our veteran population in Milwaukee. And to do this, as Saeed has sort of described, we are developing a peer mentor program or peer mentor services in the domain of opioid use. And in doing so, we're focusing on educating our peer mentors with opioid-related treatment modalities as well as prevention services for these peer specialists. We're hoping to impact that veteran knowledge so they can sort of understand some aspects related to pain, some aspects related to opioid use, as well as share their attitudes and perspective, and then to try and address the behaviors that can sometimes be aberrant that are related to opioid use. Next slide, please. Thank you. In this project model, obviously, I'm not going to read through the whole thing. However, I'll focus on a few aspects. If you look at the far left on the inputs, there's obviously many parts that make up this program. Clearly, the MCW Clinical Scholar Team, of which we are, as well as the Dry Hooch leadership, and this would be Bob Curry, as well as the staff and peer specialists, and then our Mental Health America leadership and staff, and then our community advisory board. All four are equally important into getting this program to both get off the ground, but also to maintain sustainability. We'll run through a few of the objectives and other things in a moment. Sorry, go ahead, thank you. In the project timeline, so I'll just sort of run through this. The first part is obviously creating the partnerships, and sorry for the misspelling of curriculum, but creating the partnerships is first, and that went to primarily Saeed and a very long-term relationship with Dry Hooch, as well as many other community partners that were accented by Kevin and Kajwa's relationships with these folks as well. The curricular development, so the program at Dry Hooch already has aspects of curricula, but not ones focused on opioid use and or pain. So our team went about developing that curricula for training of the peer mentors in order to work with the mentees. We then went about recruiting and training the peer mentors using this curricula. And then we obtained baseline data about the veteran population. We've developed general opioid use disorder prevention campaign. And then we will evaluate our progress, and then we will begin on the dissemination of this work. Then at the end, although this is not intended to truly end, but this project portion of it is the final reporting, and then reporting upon our sustainability efforts. Next slide, please. Now, as one would expect, this is not just from a single funding source to be able to create all of this. We've had the benefit of many additional funding organizations in addition to the Robert Wood Johnson Clinical Scholars program. We also have the MCW Office of Community Engagement. Dry Hooch itself has helped, and this is primarily through Human Work Hours, Mental Health America of Wisconsin, as well, in this case, Wake Forest University School of Medicine, which funds a considerable portion of my time to help with this, as well as MCW Family and Community Medicine, and then the School of Pharmacy also at MCW. We also have gotten additional resources from our prompt core team, as well as our academic team, and then the resources that one cannot do without in doing this type of work is our community advisory board, where there is a possibility for all the people who we are trying to affect are able to give their thoughts and perspectives on what we are doing. Next slide, please. And at this point, I will pass it off to Kajwa.
All right. So I'll be discussing the work of the project. And again, that's Otis, our peer lead mentor. So what are we working on? In terms of the engagement of the veterans, we've been using a peer-led approach, community-based participatory research for creating the opioid use disorder prevention curriculum. And the second thing is to positively impact veterans, their knowledge, attitudes, and behaviors related to opioid use. And who's impacted by the work? Ultimately, it's the veterans that are coming back from combat and transitioning to civilian life, and hearing those veterans and their voices, in addition to the peer mentors who are supporting those veterans, and then also all of the organizations that have been involved in the project that we've been doing. In terms of materials or things that have been created, this is actually a flyer that I created to help with the recruitment of the the veterans that are struggling with opioid addiction. We also have created the curriculum for the opioid use disorder prevention training curriculum. We were recently also invited as one of 2 platform presentations at the MCW Family and Community Medicine Research Forum. So myself and Kevin presented there. Other things that have been completed is that iPeer app that we kind of discussed earlier, customizing it to various questions that are related to addiction. Supporting Dry Hooch by creating an emergency response protocol for any patients that might have triggers or any potential relapses. And lastly, we were also invited by the White House Office Drug Control Policy, which provided national exposure for the importance of peer mentor models working with veteran populations. So currently we're in the stage of, we just recently recruited and did a refresher for the peer mentors while we're working on IRB and getting IRB amendment. And currently we're actually looking at working together on a simplified consent form to be community friendly. And so we're currently in the stage of engaging those veterans in peer support and the evaluation piece. And now I'm going to turn the floor over to Kevin to talk about project evaluation.
All right, thanks, Kajwa. So with respect to project evaluation, let's go to just the next slide right away. So looking at what we've done so far, we've, as Syed so eloquently pointed out, we've utilized community engagement processes to develop partnerships. And the key partnerships, as have been mentioned so far, are Dry Hooch and Mental Health America. So with Dry Hooch, the key there is that they are the peer mentors. So without them, this project can't happen. They also were very good at helping us to recruit people to participate in our focus groups, which I'll talk about in a moment. Mental Health America is crucial because they provide the peer mentor supervision for the work that they do. As one can imagine, working with people who have been traumatized, who may also be misusing opioids and other substances, this can be a very stressful work environment, and it may at times awaken some of the trauma issues that our peer mentors have also experienced. So Mental Health America provides a kind of guided and insightful supervision for our mentors to help them maintain a sense of a stable base in the work that they're doing. Next slide, please. So perhaps one of the major accomplishments that so far, in addition to recruiting peer mentors, is that we partnered with both peer mentors, veterans, and family and friends of veterans who may be struggling with opioid misuse issues to, in the form of focus groups, to help guide us in understanding what were the important things that would need to be addressed, both in terms of training for peer mentors, but also in terms of helping peer mentors do their work. So as a result of those 3 focus groups, we identified 6 primary themes that emerged from the discussions. And I'll just briefly talk about each one in turn. Impact of trauma. In this particular theme, we're talking about what is trauma, how does trauma combine with chronic stress to impact health on various levels, both behavioral health as well as physical health, and how does that impact or connect with opioid misuse and other risky behaviors as ways of coping. And then the second theme, trauma-informed care, has to do with developing an understanding that whenever one is working with a peer, that it's likely that that peer has experienced significant trauma in their lives, either as a veteran, a military person, or even in their civilian life as children or as adults as well. And so it becomes important to incorporate that understanding into how the peer mentor relates to the veteran. Instead of dictating, for example, partnering with them to identify their issues and their concerns and motivate them to get some help. We all learned from our focus groups that veterans who misuse opioids often have a very small, narrow window of opportunity when they're most likely to be willing to reach out for change. And so we've incorporated the art of influencing others into the training as well. And this actually comes from right out of the book that we all received in one of our recent intensives as well. So we actually took that material and turned it into a brief curricular piece for working with the peer mentors. The Science of Pain medication gives them foundational information about kind of the neuroanatomy and physiology of pain and how it works, and also how medications such as opioids work to reduce pain. And then relapse prevention is a piece in which the understanding that we might be able to, through the peer mentors' help, get a person into treatment, but they may struggle with recovery issues afterwards. And so the peer mentor develops skills around helping a person to anticipate these things and develop plans to prevent it. And finally, self-care and wellness strategies. This one is an interesting theme, and it's kind of a two-edged sword, so to speak. So on the one hand, it sensitizes the peer mentor to the notion that their veteran peer who has chosen perhaps opioid use or other risky behaviors as a way of coping with their pain, their internal pain of trauma, but at the same time, so they may lack other skills to be able to take care of themselves in healthy ways. So it equips the mentor to be able to help the veteran with developing some alternative coping strategies and self-care strategies. On the other hand, as I mentioned a moment ago, many of our peer mentors also are dealing with their own recovery issues, and we recognize that, and they recognize that going into this work with their veteran peers may also be stressful for them in terms of bringing up their own prior traumas and adversities. And so the self-care and wellness strategy component is also meant for the peer mentor to take care of themselves in this process as well. Next slide, please. Okay, so in terms of process and outcome evaluation, you saw it on the logic model, so I won't spend a lot of time with it now, but we are certainly interested in looking at the number of veterans who actually request opioid use disorder treatment, as well as seek prevention services from a peer mentor. We also want to positively impact the veterans' knowledge and attitudes and behavior related to opioid use. So we've put together a fairly hefty battery of evaluation tools, which I'll show you in a few moments. But the idea there is basically to assess the impact of mentoring on a number of psychosocial issues that are relevant to our peers. We plan to collect data at baseline whenever a veteran is recruited into the program. They'll complete a baseline survey. It consists of about 160 items. And so the way that we have strategized to reduce respondent fatigue, so to speak, is to actually conduct the survey as a kind of interview. We also see that as a way of building trust and relationship with their peer mentor. We then, about 6 weeks into their involvement, plan to do a midpoint survey and then a final survey at 12 weeks. We also will be having the peers complete weekly assessments, and then we can go to the next slide. And these weekly assessments will be either in the form of red cap, if they choose to have a link sent to them via email, or the iPeer Quick Reaction Force app that can be right on their phone. So we all became familiar with red cap at our recent Robert Wood Johnson intensive, where all of our evaluations went into that. It's a really great web-based data management system that really efficiently allows us to analyze changes in attitudes and beliefs and other factors that hopefully will come up about as a result of their involvement with a peer mentor. Next slide. So this is an example, for example, of one of the questionnaires that we'll be having respondents complete. So it's an example of from the PTSD checklist, the PCL-5. And so the peer mentor will read the item off to the person, and they will then give their response to it, and they'll go on to the next item and so on. Go ahead, next slide, please. And this would be, again, an example of a weekly assessment using the iPeer or using an email-based link. So again, asking them, how strong were your cravings this week, and what other kinds of things? Have you engaged in any risky behavior this past week, and so on. So next slide. So this is the list of our instruments used, and these were selected primarily to help us kind of tap into the experiences of veterans and veteran-related risks, as well as some non-veteran related risks. As you can see, we're also measuring adverse childhood experiences, but a lot of these have to do with things that the veteran experienced in the military, as well as in their post-deployment life. So next. Okay, so I'm now going to turn this back over to Rob, who's going to talk about Project Next Steps.
Like, for example, we're in this opiate space now. We're doing this project with Dr. Syed. Out of that comes education, knowledge into the community, right? Dry Hooch, and I say this, we service veterans, but not exclusively. My hope for Dry Hooch is to, Dry Hooch, we integrate families and the community with the veteran. That goes all over the place, I see, my hope is that continuous substantial peer support be done. We have an iPeer program also that we work with the medical college on, which is a big thing, right? They've done some manuals with us. This is all done because, in my opinion, right, because Bob Curry, right, who's the founder of Dry Hooch, had a great mission. He had a great vision. What he experienced, he didn't want anybody else to experience. And to this day, he does a lot of presentations, right? I'm kind of like this wingman. So I feel that gap whenever things need to get done, along with the medical college and folks like Dr. Syed. This can go all over the place. This can expand to the research being done for veterans can also be utilized in the community, in the secular community,
All right. So Otis sort of speaks to our dissemination and the point where he says it can go all over the place. That's certainly what we hope to be able to do. We are integrating these materials into the peer mentoring of Dry Hooch. So in addition to alcohol, as well as other things that they have worked on in the past, the opioid modules become part and parcel of Dry Hooch's mentoring program. We also intend to build on the success of the peer support model and use it in multiple other traditional healthcare situations as well as models. And then we also have the more traditional dissemination of standard academia, which includes publications, posters, and presentations. But what we really want to focus on is the training for the vets. And in many cases, we're hoping to be able to expand upon or beyond veterans to other populations at risk for opioid use disorders. And in this, we were hoping to be able to move this in the veteran and non-veteran population outside of Milwaukee to other communities, for example, communities in North Carolina. If I could have the next class. There. So sustainability, we talk about this often in our in-person sessions, and this is absolutely key to keeping this going, is where does one get additional funding? In our case, we continue to look at federal resources as well as private and state resources. But then one of the other areas that many people have used in the past for these types of programs is philanthropic sources. So we continue to look for those as well. And then part of sustainability is if one can impact a policy, legislation, regulation, something along those lines, one can actually ingrain this approach to the care of others. An example of this is peer mentorship and peer specialists do not have a billable function within a inpatient hospital setting. However, addressing this and trying to work through our advocacy is trying to get a inpatient billing function for peer specialists. This would then allow more of those specialists within other locations, and that would also help sustainability. One aspect of the other aspect of dissemination and sustainability is if one can gain national exposure for these types of programs and get it disseminated through that exposure. And then the peer mentoring program, the wonderful part about this is we have integrated and really partnered with a group that has a many-year mission and history. So we have great optimism that this program will continue regardless of what happens to the four of us. So with that, we think there is an excellent sustainability initiative for at least this local program. Next slide, please. I'll pass this over to everyone, I guess, but please, everyone else can speak.
Well, all right, I'll jump in first. So in terms of lessons learned, and I'm trying to connect these to some of the competencies from our fellowship, a couple of lessons that have really jumped out for me are the importance of thought diversity and embracing thought diversity. You know, when we're working with a community, with community partners, and even within our team, as a multidisciplinary team coming at this from very different perspectives, that it really is important to embrace that and to be comfortable with dealing with differences of opinion or differences of perception, and then tying that to a second competency, being able and comfortable having crucial conversations that where sometimes the conversation may get spirited and take on sort of the form of a debate, but at the same time it's always respectful and you know, dealing with some of these difficult issues. Some of the issues that I think have come up frequently in our discussions, issues of race, issues of social class, issues of research participants' rights, and those kinds of things, and those have to be addressed. And people, you know, as a group, it's important for us to come to understanding, and even if it's not universal agreement, at least a consensus and a respectful disagreement at times.
And then for me, as a clinical pharmacist, I'd worked in chronic pain management and kind of had the oversight for patients that were on high morphine equivalent dosing. So I was very new to Milwaukee when I started with the Clinical Scholars Program. But with our work with the project, I've learned a lot about just the cultural humility working with veterans. And we actually have incorporated veteran kind of interprofessional elective as well as training around working with veterans within the pharmacy school curriculum. So that's something that I actually took home in terms of that piece. Also, as a new department chair, I was very new to my role, and I don't think I could have grown this much over the last couple of years without this program, this leadership program from the on-site training, so I have me time, to ensuring like I have an individual coach. I've passed along several of the little nuggets that we've been learning, like managing difficult conversations, emotional intelligence, the powerful apology. We even created peer coaching groups. And so there's various things that I've passed along to the School of Pharmacy, because I oversee approximately 25 faculty. So there's definitely a lot of challenges that have happened in the last 2.5 years with even my current role, but also within my current role, there's a lot of rewards. So this is a picture of me getting the Professional of the Year award by the Hmong, Wisconsin Chamber of Commerce. And so it was a group of 500 people in the room. So it was actually very nervous when I was up there, but that's one of the achievements that I've had since being in the program.
Saeed, are you muted?
He may be. Let me see if I can help.
You can go ahead.
There we go. Yes, now we hear you, Sad.
Rob, you can go ahead.
Oh, sorry. So there are many lessons learned, both locally as well as from the program in the greater aspect. Locally, one of the things that I learned, and Kajwa used the right term, at least the one that fits for what I'm thinking about, and that is humility. One aspect of working with the peer mentors, but also in giving just a lecture to the peer mentors, the questions that they ask, they really open up your mind, because sometimes in the world of academia, we sometimes lose, or at least I lose, perspective of what some of these people are going through. And listening to them has actually been exceptionally valuable, and it's opened up my perspective in how I do therapy and treatment in my role, in my clinical role here in North Carolina as well. And then on a more broad perspective, one of the things that has come to be crystal clear for me is the immense necessity, not value, but necessity of relationships with the community in which you are trying to work, help, or advise in some cases. Sorry. And that, sorry, I just lost. If someone could hop on, I just lost my computer connection.
We can hear you.
You can hear you, Rob.
Here you go. Yeah.
You can? Okay, I apologize. I just lost my computer screen. Well, yeah. Children's school is calling. So the big thing is the understanding of the community engagement, and seeing the importance of that engagement has been very powerful, because watching how much the peers as well as the Dry Hooch program respect the involvement of the MCW folks has been clearly, it is a excellent relationship that goes in both directions. And I think that is one of the big things that I've learned from this, is not community engagement is far from a hand waving exercise or a checkbox. It's really much more valuable when there is such deep connection.
So for me, the multiple things I need to bring it up. One is just going back with what Rob just said. Our peer mentors, they're really partners, and they understand that, feel it. They're also part of developing the program at every level. Even the book Influencer, I gave a copy to Otis. Otis and I developed the Influencer module. And that was wonderful. And I think that made it, I think, more real for anyone creating a module such as influencing others. And all the other pieces what Rob mentioned, even presenting to the peer vet mentor is an experience by itself. Listening to their stories in the focus group was very eye-opening. And one day, hopefully, we'll be able to share some of the stories, which was tremendous. But on the other level, as a physician, I deal with opioid whole life and have been, I think, vocal critic of abuse of these medications for a long time. but I learned even more just by doing this. As a community engaged researcher, I have been doing community engagement for 30 some years. But I tell folks, if you have done one community engagement program, you have done one community engagement program. Don't get too used to it that you know all the answers. Again, this was a perfect example. Our program was going very smoothly for basically more than 2 years. Then within 2 weeks, we had crisis in all three partners of different level, from the MHA to Dry Huge and MCW. For us, it was losing our glue, the main coordinator, leaving suddenly for her own reasons, had really impacted. But with the support of everyone from the faculty and staff, and some of the folks who are not even in the picture, like my program manager, Sarah, and now we have Maya, the new person coming in. God's blessing, wonderful blessing that people are back in again, track again. So those are the things you face and you do it. But on the other hand, I always teach other faculty that if you have done community engagement, you didn't get yourself in trouble, you have not done a community engaged program. So this was one of the fantastic example even for me after 30 years. Lastly, I would say that this is a learning experience, even as a senior researcher in this field. As much as sometimes I do not understand how much time I'm going to use for my GIT modules and OUTs and others, but those are the ones, and some of the books and the webinars and some of those retreats with colorfully named, all of them have been wonderfully helpful. And looking back, every time I actually tell other folks, this has been one of the best learning experience at multiple levels. So I'm going to more or less stop here. And there are a couple of other slides. Those are just slides for some of the research thing we have. We don't have to go through any of those. But this is the time I like to thank everyone, my clinical scholar colleagues, my staff, all the peer mentors, Dry Huge, MHA, and of course, our RWJ clinical scholars, all the folks, Rachel, and everyone else. I cannot thank anyone enough. So I think we try to control as much as possible. We left 10 minutes. So we are open for any Q&A. Thank you.
Awesome.